the area of this inborn errors of metabolism in children. And I also welcome all the office bearers of IAP, state IAP as well as IAP Kottayam, and also senior faculty, Purushothaman sir, and all of the teachers and all the participants, and including faculty and residents. So, madam, we can start the program.
Good evening, senior faculty members and dear friends. It's indeed an honor and a great pleasure to be here this evening, and I congratulate IAP Kottayam for selecting this topic, which is very close to our hearts. And we have so many children, like although they are known as rare diseases, our work has confirmed that they're really not all that rare. And I'm so happy Dr. Susy has taken it up there. And I think this should be very useful for postgraduate students because there are several diseases. It's a heterogeneous group of diseases with various and varied presentations. And it's not all that easy to diagnose unless we really look at it carefully. So over to Dr. Susy to start the session.
Thank you, madam. And I initially tell my thanks and regards to the IAP Kottayam branch for giving us the opportunity to present this PG OSCE session. And the topic is inborn errors of immunity. So I am projecting the zebra and think zebra initially, which is by the Immune Deficiency Foundation. The zebra in inborn errors of immunity is because it's told that when you hear the sounds of hoof, you think of horses. So that means you get a scenario of a history and a clinical presentation. You are thinking of the common possibilities by your differential diagnosis. So when you hear the hoof beat, you think of horses. But in inborn errors of immunity, it said that when you hear the hoof beats, you think of zebra. That means you have to think out of the box because only if you have knowledge about the inborn errors of immunity, you will have subtle clues from the history and general examination and physical examination and investigations which are pointers towards inborn error of immunity. So that is why the think zebra is the depicted in the Immune Deficiency Foundation. So when you hear of hoofbeats, you think of zebra. And this is the Immune Deficiency Foundation of the world. So we'll come to a brief introduction about the inborn errors of immunity. So this is initially, life is not about waiting for the storm to pass. It's about learning to dance in the rain. So I'll be showing this is Jeffrey Modell. So he was a child who had succumbed to a immune deficiency disorder. Probably he had an antibody deficiency and he lived for 15 years. And his parents, Vicky and Fred Modell, were too much involved and too much worried about his disease because at that time he was born in the 1970s and nobody had the protocols or this thing to diagnose an immune deficiency. Further investigations were not available and the treatment options were also limited. So after his death in 1986, that is about 15 years, they put forward the Jeffrey Modell Foundation. So you will be all aware of the Jeffrey Modell Foundation 10 warning signs of immunity, which is put under his after the name of Jeffrey Modell by his parents Vicky and Fred Modell. So this is Vicky, and it's told that he used to tell always like, please mom, dad, please doctors, do something. Because you are doctors, you had gone to college, you have the knowledge, have the caliber, please diagnose my disease. So he was intelligent enough to know that he had a disease, was underdiagnosed and which did not have a definite treatment. So this is Jeffrey Modell. And like we celebrate all the days or weeks, there is a World Primary Immunodeficiency Week. Test, diagnose, and treat, and that is from 22nd to 29th April. So, a World Primary Immunodeficiency Week is celebrated between 22 and 29th April, and the theme of this year is See the Unseen and Unite to Uncover the Stories Behind Immunodeficiency. Now, all of you are aware about the 10 warning signs. There are 4 or more new ear infections within a year, 2 or more serious sinus infections within a year, 2 or more months on antibiotics with little effect, 2 or more pneumonias within a year, and failure of an infant to gain weight or grow normally. Recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infection on the skin, need for intravenous antibiotics to clear infections, 2 or more deep-seated infections including septicemias, and most important, a family history of primary immunodeficiency disease. So let me come to the functions of the healthy immune system. We'll be under the impression that the immune system is only protecting us from the invading microbes, but it is also having an important role in deleting the autoreactive cells, thus preventing the autoimmunity. And the cells in the immune system are also keeping a check on the mutant cells and preventing the cancer. So, unlike your basic this thing that the immune system is not only predisposing to recurrent infections, it is also having an increased risk of autoimmune diseases and an increased predisposition for malignancy. So, any disorders of the immune system will not only predispose to increased risk of infections, but also to increase autoimmune diseases and predisposition for malignancy. So, in general, when you have a severe infection or a prolonged infection in multiple sites, infection by unusual organisms which are resistant to antibiotics and difficult to treat with a family history of immunodeficiency, definitely you have to rule out an immunodeficiency disorder by a proper clinical examination and investigations. And just to have an overview, most of the immunodeficiency disorders are antibody deficiency disorders, which are affecting the humoral immunity. Then there are disorders affecting the combined immunodeficiencies, B and T cell disorders, then defects in intrinsic immunity and the innate immunity, then phagocytic defects. Then there are certain immunodeficiencies with well-defined syndromes. Then there are diseases of immune regulation, and least is the complement deficiencies. Now, you might know, like I'm talking about primary immunodeficiency diseases, but the heading is inborn errors of immunity. So, actually, the name primary immunodeficiency diseases was renamed in 2017 by the International Union of Immunological Societies with the term inborn errors of immunity. So, earlier, the inborn errors of immunity was called as a primary immunodeficiency diseases, and it was renamed because, as I told, it is not only dealing with infections, it is also dealing with autoimmunity and increased risk of malignancy. And although they are individually rare, the prevalence is high, so we need to have a knowledge about the clinical manifestations and investigations to make a proper diagnosis. And most of them are single gene disorders, monogenic disorders, and there is genotypic and phenotypic heterogeneity also. So genetic diagnosis is also important, not only in getting a proper diagnosis, but it will also aid in the prenatal diagnosis and even targeted treatment. And because whenever we are speaking about immunodeficiencies, we should know what are the CD markers. So they are the clusters of differentiation antigen which are found by the flow cytometric analysis. And T cell has got CD3 as a marker, helper T cells as CD4, cytotoxic as CD8, B cell marker is CD19, CD20, and NK cell, that is a natural killer cell marker, is CD16 and CD58. And there are many other markers also, because as we start with our OSCE, you will understand about the naive helper cells and the memory helper cells. So each cell has got a particular CD marker, and by flow cytometric analysis, the CD marker, we are able to arrive at a diagnosis in most of the cases. So this was a brief introduction about the inborn errors of immunity. Now I request Dr. Geeta Madam. Geeta Madam is actually the pioneer in immunodeficiency disorders in Kerala, and the Immunological Society of Primary Immunodeficiency Diseases in India And one of the institutions is a Calicut Medical College, the pediatrics department, which is only because of her sincerity and dedication, she was able to include the department. So over to Madam for the starting of the OSCE. Stop share.
Yeah, thank you, Susy, for those very kind words. Yeah. You stop sharing?
Madam, stop sharing. Madam, share.
Yeah.
Tare.
This one. Okay.
Madam, okay, share that. Madam, any other?
Okay.
താഴെ മേലിലുണ്ട്. Okay, madam.
Okay. So today we'll quickly go through a few OSCEs. Am I audible?
Yes, madam.
Clear?
Yes, madam.
Okay.
Clear,
Yes.
madam.
Yeah. So we'll go through a few of the objective structured clinical examination possible questions. And I'll do a few in the beginning and then Dr. Susy will take over. So let's start away quickly with the first question. Is a 10-year-old boy having recurrent fever every 3 to 4 weeks, early onset, 3 months, gastrointestinal symptoms are there, also had recurrent cervical adenitis and oral ulcers. And when he came, he had arthritis of both knees and mild hepatosplenomegaly with polymorphonuclear leukocytosis, elevated ESR, CRP, and a negative ANA-IF. And his IgA was elevated and IgE was elevated. So this is the scenario. 10-year-old male child coming with multi-system involvement, including recurrent fever from early in life, from 3 months of life. So the questions would be, what is the most likely diagnosis? How will we confirm the diagnosis? What is the mode of inheritance? Recommended treatment? And if the first line treatment fails, what are the other 2 drugs that we can use? So would any of the students like to answer?
Nivedita is there? Nivedita? Manjuja? Samiha?
Yes, ma'am.
Please.
Samiha can answer.
Yeah, what is your answer, Samiha?
Madam, autoinflammatory disorder.
Oh, excellent. That's a great diagnosis. Any specific one? So early onset gastrointestinal symptoms every 3 weeks, lasting 3 to 4 days. So, the most common one in our area is mevalonate kinase deficiency, previously known as hyper IgD syndrome. Confirm the diagnosis by exome sequencing. If there's an affected member already, we can do Sanger. Autosomal recessive, and initially NSAIDs. No response to NSAIDs, we can give steroids. But if there is no response, or if the dose of steroids is very high or leading to adverse effects, then the other options are biologicals, including the IL-1 receptor antagonist and anakinra and the anti-IL-1 canakinumab. So these are the answers. Let's go to the second one. So this is not really all that rare. So a wide spectrum of presentations. Although we have most reports from Western Europe, we do have a few reports from Asia, and we have a large cohort. So what happens when there is mevalonate kinase deficiency? There is inactivation of Rho A downstream, and stimulation of the pyrin inflammasome with increased production of IL-1 beta. And these are the symptoms. Gastrointestinal symptoms are prominent apart from rash, arthralgia, fever, lymphadenitis, mainly cervical. And flares occur on exertion, on vaccination, and stress, and various other reasons. Now let's go to question 2. The newborn, a term age a male baby, coming with fever, seizures, and mild facial dysmorphism. There is a positive blood culture, echo showing a truncus arteriosus, and there is CBC, you can see. Lymphocytes are on the lower side, ILC, hypocalcemia, and absent TRECs on newborn screening. TRECs are the T cell receptor excision circles. Now, what is the likely diagnosis? Anyone? JRs?
Kiran is the Jetsi.
Is it DiGeorge, ma'am?
Excellent. Yeah, that is exactly. And would you want to qualify it further? Because there are no TRECs on newborn screening, no T cell receptor, so we would call it as complete DiGeorge syndrome. Okay. Diagnostic test?
Fish.
Very good. Fish or MLPA. Non-cardiac complications?
Hypocalcemia.
Yeah. So we can get renal anomalies. Okay.
Yes,
We can
ma'am.
get
Phonotruncal
tracheo-
defects.
Yeah. Laryngotracheal anomalies.
Malish.
Mode of inheritance? Autosomal dominant.
Dominant. AD, ma'am.
Yeah. Curative treatment for this patient? Because it's complete DiGeorge syndrome, what would be the treatment? It's almost like a severe combined immune deficiency.
HSCT.
Exactly. Yeah. So you can either do HSCT or a thymic transplant, which is not done here. It is available in certain centers in the West. In the UK, they are doing thymic transplant. Okay. So you can see here the diagnostic fish. So instead of 2 green signals, only 1 red signal is seen, showing the micro deletion actually. And you can also see it on MLPA. And here you can see the fish images, a normal fish image on the left side. And on the right side, you have the abnormal fish image in a child with DiGeorge syndrome. Now, the question 3 is about newborn screening using the TREC assay. Okay. So now, in Calicut, we are doing as part of a project, the TREC assay. Now, what is the technique used for this test? Anyone? The T cell. So it is a?
Remisa is the?
Yes, ma'am, but I don't know technique.
Yeah, it is a RT-PCR based test. Okay. And which diseases can be diagnosed? So SCID is one, isn't it? Huh? The others are other combined immunodeficiency disorders, and KREC is the kappa deleting receptor excision circle. That is for the B cell defects. So the TRECs and CRECs represent naive T cells and B cells respectively. So X-linked A-gamma globulinemia, you will have low CRECs. Okay. And which types of SCID may be missed? Leaky SCID or hypomorphic SCID, ADA deficiency, maybe late onset, and ZAP70 deficiency, and 3 conditions causing erroneous results. Prematurity. So if it is less than 32 weeks, we need to repeat it. Multiple congenital anomalies and heparin contamination. Ataxia telangiectasia also will have low TRECs. Okay. Next one, we are going quickly to the next one. It's a 2-year-old boy, fair skin, gray hair, having recurrent pneumonia and bruising. He also had, apart from hepatosplenomegaly, severe pallor and generalized lymph node enlargement. Peripheral smear showed severe anemia, neutrophilic granules were there, thrombocytopenia was there, and ferritin, triglycerides, and D-dimer were elevated, and the bone marrow showed hemophagocytosis. Okay, so what is the likely diagnosis? JR?
Dakshina is the Dakshina.
Dr. Dakshina?
Okay, Jetsi has given the answer. Jetsi, you can answer.
Chediak-Higashi.
Very good. And what is this life-threatening complication which the child has?
HLH.
Exactly. So hemophagocytic lymphohistiocytosis. What is that image that you saw there? What is that image?
Albino hairs.
Yeah, it is a trichoscopy image showing the hair with the melanin clumps. Okay, so the uniform melanin clumps in Chediak-Higashi syndrome. Okay, and how will you manage this child? Management?
HSC.
That would be the curative treatment. Before that, what will you do? You need to manage the complication, isn't it? Huh? So, you give steroids, IVIG, etoposide or methotrexate. Okay. And how do you make a diagnosis? On next generation sequencing, you will see the LYST, lysed or CHS1 gene variant will be seen. Okay. And curative treatment, you've already said. And in the trichoscopy, you can actually differentiate from Griscelli syndrome. In Griscelli syndrome, you have irregular clumps, mainly in the medulla. Here it is uniformly distributed, smaller granular clumps. Okay. So, there is also a life threat, a complication which can occur later in life. Can you mention? So,
Dakshina.
So some individuals, yeah.
Neuropathy.
What is it?
Neuropathy, ma'am.
Exactly. Very good. So full marks to you. So you may get spinocerebellar degeneration, ataxia, various other neurological symptoms, including dementia. So that can happen in spite of allogenic stem cell transplant. So this is what happens. So you have reduced bactericidal activity and impaired chemotaxis, abnormal platelet aggregation leading to bleeding, fewer dense granules are there, and the defective cytotoxicity of the NK and the cytotoxic T lymphocytes. Now, question 5 is an infant, a 10-month-old male baby, admitted with recurrent respiratory infections and indolent ulcers, but having no pus. There was a history of delayed fall of the umbilical stump, and CBC revealed marked persistent leukocytosis. Now, questions are very simple. What is the probable diagnosis? JR?
Neetu can answer.
Madam, leukocyte adhesion defect.
Yeah, excellent. So we would say leukocyte adhesion deficiency type 1, which is the commonest. In type 3, you may have associated bleeding manifestations also. And what immunological assay will you perform? You will measure the surface expression of CD18, CD11A. And how will you confirm the diagnosis? Again.
Neetu can answer.
Neetu? What is the confirmatory diagnosis? So again, you will do an exome sequencing, next generation sequencing, and you will get an ITGB2 variant, a variant in the beta integrin gene. And what is the curative treatment?
X-HIGM.
Yeah, HSCT, allogenic HSCT, or gene therapy. And management also includes antimicrobial prophylaxis because they are prone to bacterial infections. Oral hygiene, it's very essential to maintain good oral hygiene because they have a propensity to develop severe gingivitis and falling out of the permanent teeth. And prompt, appropriate treatment of infections is also essential. Okay. So this is showing the red indicates the patient and the blue is the control. So you have reduced or absent CD18 or CD11A expression. And in fact, this is a prognostic test. So if the expression is found to be less than 2%, it is severe, and that child will require a hematopoietic stem cell transplant. But if it is moderate, mild to moderate, with the CD18 expression being above 2%, they can be maintained on just antimicrobial prophylaxis and attention to hygiene and prompt treatment of infections. Sixth question. Here we have a 4-year-old boy, non-consanguineous parentage, recurrent pneumonia requiring repeated PICU admissions, mechanical ventilation twice. So, severe pneumonia, okay? And it's also, the frequency is increased and severity is also high. Also had persistent diarrhea at the age of 1 year. Mother has a history of having lost 3 of her brothers during her childhood. We don't know the exact reason. And evaluation showed that the boy had hypogammaglobulinemia and low IgA with normal IgM levels. And the basic lymphocyte subsets that Susy showed you, CD19, CD8, CD4 and all were normal. Now, the questions. What is the most probable diagnosis? Who's going to take this?
Kiran?
Dr. Kiran?
Megha? Okay, Samiha can answer.
Madam, agammaglobulinemia.
Yeah, the thing is here, let's just go back. What happens in agammaglobulinemia? You'll have pan-hypogammaglobulinemia, isn't it? So, IgA, IgM, IgG, all will be low. Here, IgM is normal, but the others are low. So, what could it be? So, it could be hyper IgM syndrome. I just put this slide so that we should know that in hyper IgM syndrome, you need not have an elevated IgM. It just need to be normal or elevated. But the other immunoglobulin classes will be low because of the defect in class switch recombination. Only IgM is being formed, but the other immunoglobulins are not being formed. So normal or elevated IgM. How will you confirm the diagnosis? What will be the, yeah.
Samiha can answer.
So in hyper IgM syndrome, X-linked, what would be the variant?
Neetu?
That's okay. You will have a CD40 ligand variant. Okay. And how will you, this is, here you can see the immunoglobulin profile with the low IgG and the normal IgM. And you will find that the expression of CD154 is, you can see it's 0% in the patient. So that is representing the CD40 ligand. So you have the X-linked syndrome. So how will you manage the child? Periodic IVIG, antimicrobial prophylaxis. Sometimes they have neutropenia, then we may have to give GCSF. 2 gastrointestinal complications. So you can get Cryptosporidium parvum infection. It is very common among these children, and they are prone to develop malignancies, including hepatocellular carcinoma, cholangiocarcinoma, colitis also. Curative treatment is allogenic, hematopoietic stem cell transplant. I think this would be the last question. A 5-year-old girl, look at this plaque-like lesion, which is there from the newborn period at the BCG site, and she also had left axillary adenitis. She complained of low-grade fever on and off, poor weight gain, but no contact with tuberculosis. CBNAT was negative. The lesion reduced in size and the child started gaining weight on anti-tuberculous therapy. What is the likely diagnosis? Anyone?
Ramisa.
So,
Jetsi.
Yeah.
Anyone can answer? Jetsi.
You can try, no problem.
I'm not sure, ma'am.
You can just say what you feel. Need not be correct. It's a difficult one.
Mendelian susceptibility for
Purushottam sir. Sir will always have the right answer. So, like sir said, there is, thank you so much, sir. Mendelian susceptibility to mycobacterial disease, where there is susceptibility to non-tuberculous mycobacteria, okay, including the BCG strain. And not only that, actually the name is a misnomer. There's also susceptibility to Salmonella, Histoplasma, Cryptococcus, and viruses like HSV1 and 2. And what is the defective pathway? It is the IL-12-23 interferon gamma axis. And the treatment would be prolonged anti-tuberculous therapy, maybe from 12 to 18 months or longer, depending on the response, and azithromycin. Azithromycin can be used as prophylaxis also after the treatment. For genetic defects, IFNG, interferon gamma, or gamma receptor 1 or 2, or IL-12 receptor beta 1 or 2, STAT1, GATA2, IKBKG, and NFK. These are some of the genetic defects associated with this condition. And other inborn errors of immunity with increased susceptibility to tuberculosis include SCID and chronic granulomatous disease, apart from MSMD. Okay, so thank you so much for listening so patiently and interacting. Let's all of us together make life more beautiful for these affected families. Thank you.
Thank you, madam. Now
I'll
we'll
stop sharing.
Thank you,
go
madam.
to the next set of OSCEs.
Okay.
Is it visible? Thomas, is it visible?
Madam, okay, madam. Okay, madam.
Okay. So we'll come to the next set of OSCEs. Please listen carefully. Move cheyyunnilla. Okay, so this is a 6-year-old male child who was referred from the ENT department in view of repeated episodes of otitis media and maxillary sinusitis. And he was detected to have recently bilateral conductive hearing loss and gives a history of chronic productive cough for more than a month. And on inquiry into the deep history, he is having repeated episodes of infection from 9th month of age, most of them in the form of sinopulmonary infections, respiratory tract infections. 2 of them required PICU admission, one at 1 year and the other at 3 years. And on examination, he has mild pallor. He has grade 2 pan-digital clubbing. Saturation is 97 normal. Bilateral ear shows purulent discharge. The respiratory system shows crepitations in the bilateral interscapular area, right more than the left. Investigations reveal a hemoglobin of 8.7, total count of 6,000, ANC and ALC normal. That is absolute neutrophil count and absolute lymphocyte count is normal. Platelet count is normal. And the culture from the ear discharge is growing Streptococcus pneumoniae. So is it clear? So he is a 6-year-old male child, recurrent sinopulmonary infections, recently detected to have bilateral conductive hearing loss, productive cough for 1 month, general examination showing pan-digital clubbing, with respiratory system showing crepitations and culture growing an organism. So lot of clues. So it's actually very easy for the PGs. Now please answer me. The questions are, what is the most likely diagnosis and why? Who is going to answer? Samiha, it's a straightforward question. What do you think is the most likely diagnosis? You have to tell me why you told so.
Neetu has put the answer in the chat, Dr.
Okay,
Susy.
madam. So Neetu, you can just tell
Gamma
because I cannot see the chat.
Madam, Bruton say gamma globin.
Okay, very good. But why did you tell so? Tell me the reasons.
Child presented with a recurrent END and airway infection from 9 months of age,
Okay,
usually
very
after
good.
6 months.
Okay, good.
An infection with the Streptococcus pneumoniae.
Yeah, you have the organism, that is a capsulated organism, bacteria. Okay, then anything else? Others can tell. Ramisa, what is the sex of the child? He said, Bruton's is inherited in what way, Needu? More common in males or females?
X-linked.
X-linked. So it's common in? Common in?
males.
Yeah, male. So it's a male child. Samiha. Okay, any other thing? And what is a pan-digital clubbing? Showing you pan-digital clubbing, repetitions. What does it indicate? He's a 60-year-old boy having infections right from 9th month.
Bronchiectasis.
It could be bronchiectasis. Okay, so that is it. Now next, what other investigations will you do to confirm your diagnosis? You want to confirm your diagnosis? You want to do any investigation? This is a clinical diagnosis, that is from the history and the clinical examination. Now, any other blood investigations you want to do? Samiha?
Globin assay.
Yeah, immunoglobulin assay, because the name itself tells it is A-gamma globulinemia. Okay, so what do you think? There is pan hypogamma, means there is pan A-gamma globulinemia. All the immunoglobulins are, even decreased to absent. Any other thing? If you get an immunoglobulin level low, any other thing you want to differentiate? Madam was also showing another case of hyper IgM. That's different. Any other thing? Where are these immunoglobulins produced from? Samiha, immunoglobulins are produced from the which cells?
B cells.
B cells. So do you want to know the B cells are normal or not?
Yes, ma'am.
Why? So in this case, B cells will be normal or B cells will be there?
Absent.
Yeah. So B cells will be absent. So how do you look for the B cells? What investigation you will do?
Flow cytometry.
Flow cytometry. What is the CD marker for B cells?
CD19.
Okay, very good. CD19 or 20. Okay, 90. So you suppose the immunoglobulin levels are on the lower side, all the immunoglobulins are lower side, but you get a B cell. What is the diagnosis? And the onset is a little later. Might be it is after 3 years. So what is the diagnosis?
Common variable immunodeficiency.
Yeah, so that comes to common variable immunodeficiency. Okay, good. Now, anybody else apart from Samiha, what are the common organisms causing infection? Already I have told one. Any other organisms? Ramisa?
Enterovirus.
Yeah, so that means bacteria. Any other bacteria? What is the peculiarity about the bacterial infections?
Encapsulated bacteria.
Yeah, encapsulated bacteria. Why encapsulated bacteria are commonly involved, Ramisa or Samiha? What is the relation between antibody and encapsulated organism?
Opsonization.
Yeah, very good. Antibodies are opsonizing the capsulated organisms and killing them. So it's more common with the bacteria which are encapsulated like Streptococcus pneumonia, H. influenza, even Mycoplasma. Okay. So the organisms are the bacteria. What about the virus? Ramisa was telling which virus?
Enterovirus.
Very good. Enterovirus. Why this enterovirus alone is more common here? Usually viruses are killed by what means? Is it extracellular killing or intracellular killing?
Intracellular T cell.
Intracellular. So enterovirus and one more virus is an exception. Hepatitis virus. Both the viruses are killed by extracellularly. That means antibody. So that is the reason for viral infections like enterovirus common, like your echovirus and your poliovirus, etc. Okay. Now what parasite, what protozoa? Any protozoa is killed by
Giardia.
Giardiasis. Very good. So these are the common organisms which are involved in when the immunoglobulin level is low, because Giardia is also killed by extracellular microbes. What is the main drug in prophylaxis? Main drug. I'm telling it as a drug.
IVH.
Yeah. So intravenous immunoglobulin is the mainstay of treatment. And how frequently you give, Samiha?
3 to 4 weekly.
Yeah, 3 weeks, and you have to look at the response, and you are giving the immunoglobulins which contain the antibodies. It's also having an immunomodulator effect. Okay, so main drug in prophylaxis. Can a prophylactic antibiotics to be given in this scenario? Usually the main drug is IVIG. Okay, but this is a 6-year-old child who has actually gone into, this had to be picked up earlier, because already the child has developed morbidities of CSOM, conductive hearing loss, and bronchiectasis. The end organ damage has already occurred, so he should have been diagnosed earlier. Okay. So any prophylactic antibiotics to be given here? What do you think? Neetu? Neetu has gone. Jetsi? Anybody? Samiha? So there is a role for prophylactic antibiotic here because the patient already has a lung problem in the form of a bronchiectasis. We'll come to the indications. Now, what are the 4 long-term major complications which this child can occur? Already the child has got 2 long-term complications. They're already there in the question. What are they, Samiha? Samiha?
Yes, ma'am.
Yeah, already the child has 2. One
Respiratory.
is bronchiectasis. Second is conductive hearing loss due to CSOM. Any other thing? Ramisa has told about some viral infection. What it can cause in a long-term basis? It can cause a chronic enteroviral meningoencephalitis and neurological sequelae. Clear? And even the GIT infections, inflammations persist, and they can present with an inflammatory bowel disease like presentation. Okay, so this was a straightforward case. So the answers already has been discussed, so I am not going to repeat it. The only thing why antibiotics are given in this condition is this child has got recurrent infections of more than 3 per year. Either any of these fit into the role of prophylactic antibiotic in addition to IVIG. Okay, so when there is recurrent infections of more than 3 per year, and there are severe infections despite IVIG replacement, and when the gamma-globulinic or hypogamma-globulinic patients are associated, there is associated bronchiectasis. Now, will you measure the level of IVIG for getting Samiha? Because you want to know whatever IVIG you are giving is maintaining a level, and you usually look at the trough level, and the trough level has to be maintained at least to 800 milligram per deciliter in order to decrease the occurrence of infection. Okay, so is it clear? So because the Bruton gamma globulinemia, which was picked up later. This should not occur, it has to be picked up earlier. So that is why we have to, we get all these inborn errors of immunity from other departments, from the ENT department, from dental, from ortho, because they all are having infections, even from GI infections, a gastroenterologist can refer. So all of us doctors should have a basic idea about the warning signs of immunodeficiency so that we can diagnose them earlier. Okay, now this is another scenario. Please listen carefully. It's an 8-month-old, again a male baby firstborn of a non-consanguineous parents with a birth weight of 3.25. That means the baby is a term AGA. Baby has got normal growth and development and immunized till 14 weeks without any AEFI. Okay, possibly no AEFI. Now, this 8-month-old male baby has presented with fever, cough, and breathlessness of 1 week duration, was progressing despite parenteral antibiotics and required PICU admission and non-invasive ventilation. And inquiring into the past history, the child had 2 episodes of pneumonia at 3rd and 5th month requiring admission and parenteral antibiotics. And there is a family history of maternal uncle dying at 2 years due to severe pneumonia. And the growth is normal. Oral cavity shows absent tonsils. And chest shows bilateral crepitations, but there is no hepatomegaly. Investigations, hemoglobin, the ANC, ALC, platelet count is normal. Chest X-ray shows bilateral patchioplasty. So this is again a male baby, but it's only in the infancy, 8th month, with recurrent respiratory infections, severe infections, with history of maternal uncle dying at 2 years, and has got an absent tonsil. So what is your diagnosis? It is also very straightforward. What is the most probable diagnosis and why? Anybody? Jetsi? Jetsi. Here, unlike the other case, I have not told, it's only the respiratory tract infection. It's the respiratory tract infection with absent tonsil. What is the catch? And a male child? What are the only 2 immunodeficiency disorders with an absent tonsil and lymph node?
Wiskott.
Absent tonsil and lymph nodes for only 2 main primary inborn errors of immunity. What are they?
SCID.
That means,
SCID.
yeah, SCID, very good. SCID. But if it is SCID, what is the point second SCID? What is the age of onset?
Less than 6 months.
Yeah, so this is only at 8th month. That is usually these A-gamma globulinemia, the antibody deficiency disorders will manifest only after 6 months of age when the maternal antibodies have decreased. Okay, the body should produce own antibody. But SCID with the T-cell deficiency will manifest earlier, before 6 months. Then this is only respiratory infections. SCID will have other infections and severe failure to thrive. So what is the probable diagnosis here again? Neetu? Absent tonsil, one is SCID, the other one is?
Gamma globin.
Yeah. These are the 2 major inborn errors of immunity which doesn't have a tonsil and lymph node because there are no B cells. Okay, there are no B cells. So this is also a gamma globulinemia, but it was diagnosed at an earlier age without the morbidities. Okay. Now, how can we diagnose this condition without serum immunoglobulin level and flow cytometry? Did you understand? Samiha, how can you diagnose this condition without serum immunoglobulin level and flow cytometry?
BTK gene mutation.
Okay, before going into the genetics, without if you diagnose with the serum immunoglobulin, it's obvious, and flow cytometry, it is quite obvious as it's the previous child. Any test we can do to diagnose this condition, less costlier test, which can be done in a blood bank. Blood bank?
Anti-A, anti-B antibody.
Yeah, so they are called as they are called as isohemagglutinin. That means they are antibodies which are produced against the red blood cell group antigens, like antigen A and antigen B. That will be possible only if the child has got B cells and it will produce antibody. Clear? So isohemagglutinin, that is antibodies against A and B antigens, can be detected in the blood bank. But the problem is, which blood group will not have it?
AB.
Yeah, so AB group children cannot be diagnosed with this, and since they are polysaccharide antigens, sometimes below in the infancy or below 2 years, it might be falsely negative. But if you get it positive, you can definitely rule out. Clear? So that they are called as the isohemagglutinin, which are the antibodies against blood group antigens. Okay. Now, which vaccines are contraindicated here?
Live.
Just live. What live?
Live attenuated.
Oral
Live
content.
attenuated. What? Bacterial or viral? Is BCG contraindicated here?
No.
No. Okay. So then which vaccine is contraindicated and produce a serious AEFI?
Polio vaccine.
Yeah. So all viral attenuated vaccines are contraindicated because the attenuated virus will multiply and cause disease. The most disastrous is the polio vaccine causing vaccine poliomyelitis. Okay. Now, is genetic diagnosis must in this condition? Because previously we used to tell like a patient has got a gamma globulinemia with an absent B cell. The diagnosis is quite obvious. It is Bruton. So you have a diagnosis and you know it is due to the deficiency of Bruton tyrosine kinase enzyme, which is an enzyme needed for the B cell hematopoiesis. Okay. So that is the B cell is not multiplying or it is not progressively maturing in the bone marrow. Okay, so genetic diagnosis is it must for this condition, Samiha?
Yes, ma'am, for
Why?
prenatal counseling.
Yeah, because the commonest genetic mode is the commonest inheritance is
X-linked recessive.
X-linked recessive. So, but some of the cases, majority 85% are 80 to 85% are X-linked recessive. But as in this case, this maternal brother, the uncle had died in the childhood, so that is also suggestive of it. But some of the cases can be autosomal recessive, in which the parents are carriers and there could be a consanguinity. Okay, so it's very important for the genetic diagnosis. That genetic diagnosis is important for prenatal counseling. Okay, good. Then one more question. If you give a blood or an IVIG preparation, it can cause a serious anaphylactic reaction in which type of antibody mediated immunodeficiency?
IgA deficiency.
Good, Samiha. IgA, that is selective IgA deficiency. Can you tell me the reason?
The IgA antibodies will be produced, so it can act against.
Yeah, why these IgA antibodies are acting against? Is it that way? Could you explain in a better way?
IVIG, there will be minor amount of IgA also in IVIG.
Yeah, the predominant immunoglobulin in IVIG is IgG, of course, but they have low amount of IgM and IgA. So
this antibody can react
with the what is happening in selective IgA deficiency? Suppose I am having a selective IgA deficiency, I don't have IgA in my blood, but my blood has got antibodies against the IgA. Is it clear? And the antibodies against the IgA will be of the IgE type. You understood? Because the body is able to produce immunoglobulin. So if my body is not containing IgA, it will produce IgE antibodies of the IgA type against the IgA type. So the IgA present in the immunoglobulin or the blood I am getting will cause a fatal anaphylactic reaction. So this is very important. But it is not seen in 100%. It is seen only in 40 to 45% of cases. So you have to be very careful when you are giving blood products or IVIG. Okay. Okay, now I think all the answers were answered. So only dose, everybody knows it's 400 milligram per kg. But some of them, if there is already a morbidity in the lung, you can increase the dose to double dose 800 mg per kg according to some protocols. Okay, and I already told what are the indications for antibiotic prophylaxis in gamma globulinemia in addition to IVIG. Okay, is that clear? And genetic counseling is needed. Okay, now coming to this, I will just skip because this you have to be careful because the level of immunoglobulins you are going to measure will depend upon the age. So you should have strict guidelines or strict like age distribution of each immunoglobulin will vary. So you plus or minus 2 standard deviation is taken as a cutoff. So you have to standardize and it will vary. The lab also has to be accredited lab in order to get a correct immunoglobulin result and correlate the immunoglobulin levels always with the age of the child. Okay, so we'll go to the extra. Okay, now this is another child. So these are the, it's a 3-month-old term AGA, exclusively breastfed baby who was presented with recurrent diarrhea, recurrent pneumonia, oral thrush and failure to thrive since 1 month of age. And this is also quite straightforward. The child has got absent tonsils. And what do you see in the first and the second pictures? Neetu, on the left deltoid region. What is that? Neetu, Samiha, Jetsi, anybody? Ramisa? Anybody can answer? Huh?
BCG.
Yeah, so this is a BCG. BCG, exaggerated BCG and this one. Okay. Now, what is this?
Oral thrush.
Yeah, this is oral thrush. And see this X-ray and compare it with the, what is that?
BCG adenitis.
Yeah, this is BCG adenitis and that is hepatosplenomegaly. These two X-rays, you had a look at these two X-rays. Clear? So I think it's quite obvious, quite straightforward. What are you seeing in this X-ray? Down X-ray? Which is abnormal X-ray? Both are abnormal. In what sense? Look at the thymus. There is an absent thymic shadow and this is, it's not very much clear because there is a pneumonia there. So now what is the diagnosis? 3-month-old baby with recurrent diarrhea, recurrent pneumonia, oral thrush, failure to thrive, absent tonsil. With all these findings, what is the diagnosis? And why? Severe combined immunodeficiency. Okay, good. So what is the now? Listen to me carefully. Geeta madam has already told in detail. Answer carefully. What is the gold standard newborn screening test to diagnose this condition?
TREC assay.
Yeah, TREC assay. Why you told it as TREC assay and it's not the absolute lymphocyte count? Any difference, Samiha?
In TREC assay, actually the T cell receptor rearrangement is being seen. So, in total T lymphocyte,
Yeah.
we'll miss.
What is this TREC?
TREC is the DNA particle, ma'am, which can be excised during T cell receptor rearrangement.
Okay, good. You are up to that. That is for the others to understand. You should always know that both these T cells and B cells, they are produced from the bone marrow. The B cells will not will acquire the for both B cells and T cells to function properly. They have to acquire a receptor. The B cell receptor is acquired when they move on to the peripheral lymphoid organs like the lymph node, spleen, and the other gut-associated lymphoid organ. But the T cell has to acquire the receptor in the thymus. So that is what the T cells, although when they produce in the bone marrow, for the T cells to become functionally active, thymus is required because it is inside the thymus that T cell receptor is acquired. And only after the T cell receptor has acquired, the T cell is going to be becoming functionally active so that it can take part in the immunological process. So, when the T cell receptor process is occurring within the thymus, that is the etiopathogenesis of SCID. So many enzymes are involved there. So many steps are involved there. So many genes are involved there. So this will help in the T cell receptor acquisition. But in the process of the T cell receptor acquisition, there will be the VDJ rearrangements occurring. So when the new T cells are formed, there are certain DNA things which are released from the T cell receptor circles into the T cell receptor that is into the circulation. They are actually called as the T cell receptor excision circles, and they indicate what does they indicate, Samiha? New T cells. Clear? They indicate that the T cells are formed newly and they are newly produced and released into the circulation. So TREC assay is a gold standard because if you look at the absolute lymphocyte count alone, you are likely to miss which type of SCID. That also Geeta madam has told. She has used the term leaky SCID. What is that, Samiha? Which type of SCID you are going to miss in TREC? Are you going to miss any SCID in TREC? Or
Yes,
are you going to miss a SCID by ALC?
X-linked will be missed.
All the SCID will have a low TREC. Clear? But if you take an absolute lymphocyte count, you will miss it in Omenn syndrome. Okay, and the maternal engraftment. I think we'll discuss in the coming slide. So that is why instead of absolute lymphocyte count, TREC is the gold standard. Okay, I think it will be clear in the next OSCE. Now, what are the commonest organisms causing infection? All the organisms, including the bacteria. What sort of bacteria? It's not the capsulated, those bacteria which are destroyed intracellularly. Intracellular bacteria, viruses, protozoa, fungus like Pneumocystis carinii. All the organisms which need intracellular killing are commonest here. What prophylaxis can be offered? The definitive management is, of course, hematopoietic stem cell transplantation, but and you have to do it as early as possible. But up to bridge the gap, you can give a prophylaxis with
Clotrimazole.
Yeah, IVAG is needed. Then
Clotrimazole
and antifungal. Okay, less than 1 month, you give fluconazole, and more than 1 month, you can even give itraconazole. Okay, so you have to give an antibacterial, antifungal, and also the immunoglobulins are defective or the immunoglobulins are also absent, so you have to provide IVIG. Okay, now what is the decision regarding vaccination in this case? Kid, can you give any vaccines?
Live oral vaccines should be contraindicated.
Yeah, all live vaccines, whether it is live viral or live bacterial, is contraindicated because there are no immune cells which will the disease can manifest. Okay, what about killed vaccine? Will they have any role? Where will they have? Can they be given? What is the take for killed vaccine? Jetsi. Can they be given, Samiha? Killed vaccines can be given. They are not contraindicated, but we don't know how far they will produce the effect because the immune cells are absent. Okay. Now, I think the answers have been cleared. I have told TREC assays are small pieces of DNA. Samiha has told they are small pieces of DNA created as a byproduct when T lymphocyte receptor, when T lymphocytes are rearranging the T cell receptor. So TREC is actually detecting the naive T cells. We'll come to it when we discuss the next scenario. And intracellular organisms are most common involved. And these are the antibiotics which can be given and the vaccine. Okay. Now, listen to this case carefully. This is a 4-month-old term AGM male infant born of a 3rd-degree consanguineous parents, admitted with worsening of whole body scaly rash. It's like an erythroderma. I have given the medical term also. It's an erythroderma. It's an erythematous scaly rash, which was noted since birth along with chronic diarrhea, oral thrush, generalized lymphadenopathy, and hepatosplenomegaly. So 4-month-old baby. And investigations, the absolute lymphocyte count is 4,500. The baby has got a high IgE and a high absolute eosinophil count, and the flow cytometry is showing increased T cell. What is a T cell marker? CD marker for T cell?
CD3.
CD3. Okay, CD3 is the general marker, CD4 for helper, and CD8 for cytotoxic. So we do the CD3. CD3 is normal or increased, but the marker for B cell CD19 is low, and you have a low normal NK cell. So this is the appearance of the child. So what is this condition?
Omenn syndrome.
Omenn syndrome. So what is that Omenn syndrome? Is it a type of SCID?
Yes, ma'am.
Then why the absolute lymphocyte count is high? What do you usually expect in a SCID? Because TREC assays are on the way, it's not available everywhere. You have to send the sample. So our screening method for detecting a T cell immunodeficiency is an ALC. Why? Because of the lymphocyte count, more than 70% is constituted by the T lymphocyte. Clear? So an ALC is decreased directly indicates that the T lymphocytes are on the lower side. That means suppose 100% lymphocytes are there, 70 is T cell, 15 is B cell, and 10 to 15 is NK cell. Clear? But here the ALC is higher side. Why the ALC is on the higher side? And you know, all the SCID has got a T minus. Is it, Samiha? T minus. Is it correct or no? The types of SCID you have is T minus. Then it depends whether it is B plus NK plus or B minus NK minus. All the SCIDs you know are T minus, but here it is T plus. That means the T cells are increased and the ALC is on the higher side. And you also have a high IgE and a high AEC. Why? You have correctly told it is Omenn syndrome, the characteristic erythro. So you should not miss this scaly erythematous rash that is called as erythroderma, which is seen all over the body. And suppose the patient has got all these features like chronic diarrhea, thrush, and infections, you have to suspect a SCID. Can you tell me why the T cell serum Ig and eosinophils are increased in Omenn syndrome? Any idea? Samiha?
അറിയില്ല.
Okay, so Omenn syndrome, again you told it's a type of SCID where the T cells are present, but these T cells are abnormal. They are not the functional T cells. Okay, so they are actually formed because of a defect in the RAG gene, and there is actually an oligoclonal. Oligoclonal means only one type of clone of T cells are released, and they will infiltrate into the peripheral lymphoid tissues also. Okay. And what is happening is that these T cells are abnormal, not functional also. So they are not taking part in disease prevention. And the T cells are also paving towards the Th2 pathway instead of the Th1 pathway. So when they are paving towards the Th2 pathway, there is increased release of interleukins 4, 5, and 14 or 13, which will pave way for the increased IgE and eosinophils. So, Omenn syndrome, if you take the ALC alone, you will miss it. So, that is why you are doing the TREC assay. So, what is the TREC level in Omenn syndrome, Samiha? Is it increased or decreased?
Decreased.
Decreased. You understood, because TREC indicates the naive cells. That is, the T receptor rearrangements are not taking place and the naive T cells are not released. It is because of a leaky. That is why the word is called as a leaky SCID. Because of genetic mutations, the rearrangement is occurring in a disordered way. Okay, clear. Now, what are the different flow cytometric pattern in SCID? Can you please tell me based on the T cell, B cell, and NK cell?
It can be T minus, B plus, NK minus.
Yeah.
All the three can be negative, or T minus, B plus, NK plus.
And the only SCID which has got T plus, B
Omenn.
plus, the only SCID which has got a T minus is the Omenn's. Okay, so that we'll discuss. So now what is CD45RA and CD45RO and its significance in diagnosing SCID? This is also very important. Because sometimes some forms of SCID, you have to have an idea about what is CD45RA and CD45RO. What are they?
RA are naive T cells and RO are memory T cells.
Very good. So this is also important because CD45RA stands for naive T cells, and that will be decreased in all the Omenn syndrome. What is the predominant CD45 seen? CD45RA or RO? RO. Because in Omenn, because of the decreased the rearrangements problem, what will happen? The whatever oligoclonal T cells are formed, they are immediately converted into memory T cells. So CD45 are the memory T cells and CD45RA are the naive T cells. Okay. Now, what is the caution when you give blood transfusion in SCID? What will happen if you give blood transfusion to a SCID infant?
Graft versus host.
Yeah, good. They will develop graft versus host disease. Okay, because they don't have, it does not have any naive T lymphocyte. So they develop graft versus host disease. So I think these are already explained. So CD45 RI is for naive T cells and RO is for memory T cells.
Memory.
Okay. Okay. So this is, I have just depicted to make you understand lymphocyte precursor is from the bone marrow. In the thymus, there are many rearrangements which are occurring and many levels, the genetic defects are occurring depending upon each level. And these black things are the TREC. Okay. So that indicates that the new T cells or naive T cells are released into the circulation. And this is the different types of SCID. I think you can go back and refer. The commonest one is the T minus, B plus, and the NK minus, which is the X-linked SCID. Okay. Now, this is again the same thing. Then, okay. Now, OSCE 3. This is a 3-year-old male child born of a non-consanguineous parents admitted in orthopedic department for acute pyogenic osteomyelitis. The culture grew Staphylococcus aureus. He was found to have hepatic abscess since he was having abdominal pain. So he was ultrasound abdomen was done, and along with the pyogenic osteomyelitis, he was found to have a hepatic abscess. And he had a BCG adenitis at 3rd month. History of recurrent skin abscesses and lymphadenitis at 1.5 years, all of them requiring incision and drainage. And there is a history of male sibling death at 9th month of age due to severe pneumonia. And that sibling also had a recurrent skin infection according to the mother. He is a stunted child with pallor. There is polymorphonuclear leukocytosis with raised DSR and CRP and raised serum IgE level. So, what is the diagnosis?
Chronic granulomatous.
Okay, Samiha is telling. Let's see, who is telling? So, why do you think it is chronic granulomatous disease? Quite straightforward. Right? The onset of symptom is from? When is the onset of symptom?
From infancy, BCG.
Yeah, from infancy. Okay, there are many points in the history. A male child, osteomyelitis, skin abscess, even BCG adenitis. Okay, hepatic abscess. So, and there is a raised serum IgE levels because of the chronic infection with raised inflammatory markers. Okay. What are the commonest pathogens involved and why? What are the commonest pathogens involved?
Staph aureus, Serratio marasans.
Yeah, what are the peculiarities? They are what positive? Catalase positive. These organisms are catalase positive organisms. Why catalase positive organisms are commonly involved?
NADPH oxidase deficiency is there. So.
Yeah. So, NADPH is normally producing the NADPH oxidase is leading to the formation of hydrogen peroxide, which is killing the, that means this is a phagocytic defect. That means the organism can be engulfed, but it is not able to kill it by oxidative burst. Okay. So, NADPH is helping in it. So, hydrogen peroxide is not forming. Okay. So, if it is a catalase positive organism, the catalase is destroying the H2O2, which is got by the organism from the surrounding or from the organism itself. Clear? So that is why catalase positive organisms are commonly involved. What is a confirmatory non-genetic laboratory diagnosis? What is a confirmatory non-genetic laboratory diagnosis? Not genetic, but non-genetic. Let's see what flow cytometric analysis can be done here.
Dihydrorhodamine.
Okay, this is a DHR assay or the dihydrorhodamine assay. And what can be given for prophylaxis for this condition? Which are the drugs which can be given?
Cotrimoxazole.
Yeah. Catalase positive fungi are also there, isn't it? So you have to give an antifungal. Clear? And anything else? The standard recommendations protocol sometimes tell to use interferon gamma also. Okay. So they are the prophylactic drug. Which vaccine is contraindicated in chronic granulomatous disease? This child already had it. What is that?
BCG.
What was shown in the picture? Yeah.
BCG.
BCG, because it's a mycobacterium which is an intracellular. Okay. So that BCG vaccine is, that is a bacterial, live bacterial vaccine is contraindicated. So this is chronic granulomatous disease, catalase positive. There are so many, like Staphylococcus aureus is a common, Burkholderia, Nocardia. In the fungus, Aspergillus, Serratia, Mycobacteria. So they are catalase positive. Dihydrorhodamine test is the, and trimethoprim, itraconazole, and plus or minus gamma interferon. Okay. Live bacterial vaccines are contraindicated. Okay. What is this? What is this, Samiha? What does it show? I am showing it along with the CGD. So what is this? This is a dihydrorhodamine assay by the flow cytometry. Okay, so this is the control. Okay, you should always have a control. This is a control patient, and this is the fluorescence. What is happening in dihydrorhodamine assay is when there is a dihydrorhodamine is given, because of the oxidative burst, the rhodamine is released, and that is fluorescence. That is fluorescing. So you can detect it by the flow cytometry. So this is a control patient. You can see it is, these are unstimulated, and these are stimulated. Unstimulated phagocytes, they are stimulated with the help of phytohemagglutinin or PHA. So in a control, when dihydrorhodamine alone is there, it is standing at this point. Okay, and when you are giving, when oxidative burst is occurring, dihydrorhodamine is converted to rhodamine because of the presence of hydrogen peroxide, because NADPH oxidase is normal, so it is shifting and it is the peak is occurring here. So this is normal. And this is in a affected patient with CGD, the dihydrorhodamine peak that is here. Since the hydrogen peroxide is not produced, there is no fluorescence, so it is remaining at the same level. Do you understand? So this is the patient with CGD. This is a normal child. And this is the carrier mother. And in the carrier mother, you can find two peaks. The two peaks usually indicates, this is an indirect indication that this is an X-linked CGD, because 65%, 65 to 70% can be X-linked, but the rest can be autosomal recessive also. So when the dihydramine rhodamine shows that the mother is a carrier and shows two peaks, this indicates that it's X-linked because it depends upon the lionization of the X chromosome, which is affected X chromosome and the non-affected X chromosome. So this is, some of the X chromosomes are fluorescing less, some of the X chromosomes are fluorescing more. Okay, that means some of the X chromosomes which are not lionized with the normal thing are showing this, and others are showing this. So double peak indicates that the mother is a carrier and it is a X-linked CGD. Okay. So what is NOI? You have written an NOI. NOI indicates that it's just the ratio. Okay. It is the ratio of the mean peak fluorescence in the unstimulated one with the mean peak fluorescence in the stimulated one. And normally the NOA is more than 100. That means C. That is this by this. Okay, in the unstimulated by the stimulated. So this is a larger number, this is smaller number. So this is more than 100. That is almost reaching up to 1000. NOE 1 means it is remaining at the same. The peak is occurring at the same spot. Okay, so this is the pictorial representation of a dihydrorhodamine assay. You can get it in your exam. Okay, OSCE. Now, the good old test was a nitro blue tetrasodium salt, which is outdated now because it depends upon the caliber of the laboratory technician to look for the, this is what we are using is the porcamine dye, and phytohemagglutinin is added so that the neutrophils are stimulated. The nitro blue tetrasodium is getting converted into pharmacy. So the neutrophils are turning blue color. So more than 90% of neutrophils are turning blue color, indicates that the phagocytosis or the oxidative burst is normal. So this is in a control patient, all the neutrophils are staining blue, but here the neutrophils are not staining blue. So this is not usually used now because of its low sensitivity. So this is again the same thing which I have shown. Okay. So this is what Samiha was telling. This is the phagosome and this is the NADPH oxidase. Okay, oxygen for superoxide and hydrogen peroxide. Okay, so the hydrogen peroxide is not produced for the oxidative killing of the organism. Okay, so this I think you can see. Suppose the bacteria is catalase positive. What is happening? It is a CGD patient. The CGD patient does not produce a. Suppose it's a normal patient. The normal patient produces a hydrogen peroxide. And suppose the normal patient is getting an infection with a catalase positive. What is a catalase doing? Catalase is degrading, or it is degrading the H2O2 into H2O. Okay, so the amount of H2O2 will come down. But in normal patients, because of the good functioning of the NADPH oxidase, H2O2 produced is in surplus. So the bacteria will be killed. In a CGD patient, since H2O2 is not produced and the bacteria is already having a catalase, whatever H2O2 is produced by the bacteria or diffusing from the surrounding will be destroyed. So absolutely no killing will occur and the catalase positive bacteria will produce the disease. Okay, so this is about CGD. I think Thomas, time is up. Means we can stop. It's already 9 o'clock.
Actually, madam, 10 minutes, madam. Wait.
Okay. Then there are only 2 more cases. I will finish it in 5 minutes.
No.
Okay. Now this is. So this is the picture. I have not. Sorry, I have not covered the face of the child. I had applied a concealer, but I think it not displaced. Okay. So this is the child and this is the X-ray. What does this X-ray show, Samiha? What is this X-ray showing?
Emphysema.
I think because it's projected, it's not so clear. It's actually bilateral pneumothorax. Okay. Because it's bilateral pneumothorax, the mediastinum is not shifted. And this is broad forehead, prominent chin. Okay. The fleshy tipped nose, post species. So now you would have understood, what is immunodeficiency disorder with the post species?
Hyper IG.
Okay, now we'll come to the case. It's a 3-year-old girl who had presented with pneumonia and rapidly progressed to necrotizing pneumonia with empyema and needed invasive ventilation in the ICU. And the pleural fluid gram stain and culture yielded Staphylococcus aureus. Okay. Am I not audible? Hello?
Yes,
No,
ma'am.
Madam,
Can
audible,
you hear me,
audible.
Samiha?
Yeah,
Yes,
ma'am. Yes, yes.
Hello?
Ma'am, keka, madam. Madam, keka.
തോമസ് ഒന്ന് സൂസിനെ ഒന്ന് വിളിച്ചു നോക്കൂ.
Madam, വിളിക്കോ സാറേ, വിളിക്കോ.
By that time, Geeta is there?
Yes, sir. Undu, sir.
You just continue something.
Yeah. So actually, Dr. Susy was telling about X-linked gamma globulinemia, how important it was to diagnose. So I would like to ask the residents, can you diagnose XLA looking at the absolute lymphocyte count? Any of the residents? Will you get a clue for the diagnosis of XLA from the CBC? Anybody? I think Samiha was there. Samiha has been answering all the questions. Samiha?
Yes, ma'am.
Will you get a clue for the diagnosis of XLA from the CBC? Absolute lymphocyte count? Is it possible?
Should be normal.
Why? If so, why? If not, why not? So the answer is very simple. The Susy was telling that the B lymphocytes constitute only 10 to 15% of the total lymphocytes. Therefore, even if you don't have that 10 to 15%, even if it is zero, it may not interfere with the absolute lymphocyte count. Therefore, the absolute lymphocyte count is not at all useful in the diagnosis of X-linked agammaglobulinemia. Okay, so that is one clinical point that we have. And then Dr. Susy was talking about the Omenn syndrome, isn't it? In Omenn syndrome, she was saying the CD45RA will be low and CD45RO will be high, isn't it? And the CD4, why actually, what is the reason for the scaly rash that Dr. Susy was showing? So it is actually a graft versus host disease caused by the transplacentally transferred maternal T lymphocytes. Okay, so that is the reason. And they populate other lymph nodes, the liver, the spleen. So that's why you get huge, large lymph node, lymphadenome. And what will be the immunological features in Omenn syndrome? Anyone? Any immunoglobulin which will be high?
IgE.
Excellent. And anything in the CBC?
Eosinophils will be high.
Excellent. So you may have eosinophilia. So that is something regarding Omenn syndrome. We do see it rarely, but regarding SCID, I think it is quite often being missed. Okay. So can Dr. Susy was showing so many scenarios I had shown before that. Would the residents be able to say which of these inborn errors present in the newborn period? Can you make a diagnosis in the newborn nursery? Anyone? Residents? Any IEIs you can pick up from the newborn nursery, NICU?
Wiskott-Aldrich.
Huh?
DiGeorge.
Oh, very good. Excellent. And will you have a good look at the parent's face? Is it important to interview the father, the mother, if you suspect DiGeorge in the baby? So autosomal dominant, isn't it? So looking at the facial features of the father, mother will help you. And also, they may
Geeta,
have scholastic
Geeta, you may stop your
backwardness,
video.
developmental delay, poor scholastic performance. All these
Geeta,
are features of. Yes.
Geeta, you may stop your video.
Yes, sir. Yes, sir. Dr. Susy, please.
മാഡം കേൾക്കാമോ മാഡം?
കേൾക്കുന്നുണ്ട് സൂസി.
മാഡം എന്തെങ്കിലും പറയുമായിരുന്നെങ്കിൽ കംപ്ലീറ്റ് ചെയ്തോ മാഡം.
ഇല്ല
മാഡം
നോ പ്രോബ്ലം.
മാഡം പറഞ്ഞുകൊണ്ടിരുന്നത് കംപ്ലീറ്റ് ചെയ്തോ മാഡം?
No, that's okay. I was just re-emphasizing the points, the diagnosis which we can make in the ICU. So
Okay.
The answer came as DiGeorge syndrome. The others are SCID, okay? And sometimes the other rare possibilities like ORA1 deficiency and all that may present in the newborn. In general, combined immunodeficiency and phagocytic defects present early, B lymphocytes later, okay? So, and phagocytic defects variable. Okay, right. Over to Susy.
Okay, madam. Thank you. So I was already telling it's a 3-year-old girl presenting with pneumonia, progressed rapidly to necrotizing pneumonia, empyema, needing invasive ventilation, and the empyema fluid growing, Staphylococcus aureus. So on inquiry, she has a labial abscess at 3rd month and recurrent small skin abscesses thereafter. But the peculiarity was that these were not hot, that they were not red, warm, or tender. And they did not require any incision and drainage, unlike the abscess I was talking about in CGD, which were requiring incision and drainage. They are inflammatory. Now, this child had also an episode of pneumonia at 1.5 years, requiring again PICU admission and needing prolonged antibiotic therapy. So now presented with a severe pneumonia, necrotizing pneumonia, past episode of pneumonia and past episodes of abscesses, but they were not red, warm or tender. And as I have showing, the child had a cause facies, oral cavity showed a persistent oral thrush, and nails also had onychomycosis, and dermatology, nail clippings showed candida. And a blood investigation actually clinched the diagnosis. This was a case which had actually, a real case which we had actually encountered at Trivandrum, SID. So anybody, Samiha, Neetu, Jetsi, anybody can answer? What is the scenario like, and which investigation, blood investigation, would have clinched the diagnosis? Anybody?
Hyper IgE syndrome.
Yeah. So which investigation had clinched the diagnosis? Immunoglobulin assay, isn't it? So immunoglobulin assay yielded an increased Ig level. Okay. So this case is a case of hyper Ig. Why do you tell it's a hyper Ig syndrome? What is that hyper Ig leading to? Is it causing any clinical manifestations? That is actually a misnomer. The syndrome is called a hyper Ig syndrome. But that Ig, poor Ig is very benign. That increased Ig is not causing any, practically no disease manifestations in this disease. It's just acting as a marker to diagnose this disease. Is it clear? Okay. So questions, what is the most probable diagnosis and why? Why do you tell it as an hyper Ig? So what is the basic abnormality with hyper Ig? What is the genetic abnormality, mode of inheritance, and the pathogenesis? What is the genetic abnormality, Samiha?
STAT3 mutation.
Yeah, it's a STAT mutation, and the mode of inheritance is this type of hyper Ig with a co-species is autosomal dominant. The doxate mutation is autosomal recessive. That does not have a co-species. Okay. And the important thing is that the coarseness of the facies is actually not seen in the newborn period or infancy. It will progressively appear as the disease, as the child becomes big. So that is the importance. You cannot pick the co-species in the infancy or in the newborn period. Okay. Now, what are the two organisms commonly causing this infection? I have already told the two organisms. What are they? One is the empyema or the necrotizing pneumonia caused by Staphylococcus aureus. The other one is the fungal infection caused by Candida. Okay. And what is the peculiarity of the skin abscess here? I told there were abscesses not requiring IND. There were cold abscesses. What does cold means? There is no signs of inflammation like rubor, calor, dolor. Okay. They are skin abscess. In fact, Staphylococcus are producing a little bit of abscess in the center, but overall the abscess appears cold. Now, what are the non-immunological features of the disease? That means the disease, in addition to the immunological features, are also having certain non-immunological features, which are mainly due to the role of STAT1 mutation or STAT1 abnormality, which is occurring in the bone, cartilage, and connective tissue. So that is one of the reasons for this co-species. The other manifestations can be recurrent fractures, the delay in shedding of the primary tooth, and even scoliosis. Okay. Now, to understand it better, hyper IgE syndrome is actually a triad of staphylococcal pneumonia, recurrent staphylococcal infections, staphylococcal skin abscess, and extremely high level of Ig. Okay, so these are the points which are favoring the hyper IgE syndrome. And this is very important. I have written it down so that you are able to understand. Please read with me, because I don't have any picture to explain it. So that is why I have written. It is a dominant negative mutation in the STAT3 gene. What is STAT? It is standing for transducer, activator, and transcription 3, autosomal dominant inheritance. And what it's actually doing is that the STAT gene is helping in the differentiation of T cells to suppress the IgE production. So when the STAT3 mutation occurs, actually the T cells are producing, that is, the switchover is not occurring in a proper way, and the T cells are destined to produce more of T cells. The T cells are destined to produce more of IgE. So when more of IgE is produced, the class switch is not occurring and the other immunoglobulins are not formed. So one point, the other immunoglobulins are actually low, and that is also one reason for the infection. Okay. Next one is the STAT gene mutation. That is, that STAT gene intact is important for the development of Th17 cells. So Th17 cells are actually releasing the cytokines of IL-17 and IL-22, and they are important for maintaining the integrity and immunity of the skin surface, the lung epithelium, and they will also produce anti-staphylococcal substances, and it will decrease the neutrophil chemotaxis. You understood? So when there is a STAT mutation, what occurs? The IL-17 and IL-22 are not produced, so the epithelial integrity is lost, anti-staphylococcal substances are decreased, and neutrophil chemotaxis is also decreased. Defective production of antibodies also occur. With class switching is different, IgE is produced. So did you understand? That is why I told, although it is called as a hyper IgE, this hyper IgE is only a marker for the disease for investigation purposes. The immunodeficiency is due to decreased antibodies, decreased neutrophil chemotaxis, all these factors. And that is the reason why there is a propensity for infection with Staphylococcus aureus and fungal infections, because the neutrophil chemotaxis is impaired. Since the neutrophils are not able to migrate to the site of infections, the abscesses produced are cold abscesses. So hope you understood what is the reason. And one more thing, this hyper IgE does not produce an allergic rash also, because whatever hyper IgE produced is a polyclonal hyper IgE, which is non-specific. So they are also not producing this atopy or asthma or allergic symptoms. So that is the importance of this immunodeficiency. The commonest organisms are Staphylococcus aureus and Candida. As I told earlier, the cold abscess are due to failure of neutrophil chemotaxis. And I told the extra immunological manifestations are all these. This is occurring because that is a pleiotropic effect. That means the STAT is not only present in the the cells of immune system, it is also present in the bone, cartilage, and collagen, which are important for the all these processes to occur. Okay, did you understand? So that is about the hyper IgE. And I think Thomas, will you give me 2 more minutes for the last OSCE?
Madam.
Okay.
Oh, madam.
Okay, so this is the 5th one, and I think it's quite easy. So you can see the child. I think in the first, can you make out, Samiha, something? What is that?
Peticulations.
Yeah, peticulations in the above or the below?
Above.
Okay, so these above are rashes. Okay, it's like a eczemas are there. Okay, and the lower one is ecchymosis and petechia. So I think you might have understood, right? So this is a 3-year-old male child born of non-consanguineous parents, admitted in ward with thrombocytopenia and skin bleed. So this was also a real case. So he was admitted with thrombocytopenia and skin bleeds. And so when we inquired into the history, there were episodes of blood in stools, and the mother told that he was treated as invasive diarrhea with antibiotic. And on probing further, she told that this child also had, and this child is only 3 years now. Even before 3 years, the child has got recurrent episodes of epistaxis off and on for the past 6 months and shown to ENT and was attributed to nose bleeding. And ENT visits were also there. When we asked about this epistaxis, she came forward that the child had repeated a recurrent ASOM treated as outpatient since 4 months of age. And the child is also under follow-up with a dermatologist for an eczematoid skin lesions with topical steroids, but it is not getting better. So now it's a male child, 3-year, onset in infancy with blood in stool, epistaxis, infections in the form of ASOM, and eczematoid skin lesions. It's quite obvious, right? So what is the diagnosis, Jetsi?
Wiskott-Aldrich
Yeah, so it is Wiskott-Aldrich syndrome. What is a pathognomonic laboratory finding? Because whenever you see a child of this age group with a thrombocytopenia, you immediately jump into the conclusion of an immune thrombocytopenic purpura, isn't it? But you should always look at whether the platelets are, what is the size of the platelets in an immune thrombocytopenic purpura, Jetsi? Are they bigger or larger?
Bigger.
Are they bigger or smaller? Okay, they are bigger. Okay, so you always have to look at the mean platelet volume. So the pathognomonic finding, laboratory finding is microthrombocytes. Okay. What is the mode of inheritance and how will you counsel the parents? Because this disease is always X-linked. Okay, with almost all of them are X-linked. And so counseling the parents, you know how to counsel about X-linked? 50% of the sons will have the disease and 50% of daughters will be
Carried.
Okay, I just included a genetic in it. Okay. Now, what is the reason for this recurrent infections and thrombocytopenia? Why should a recurrent infections occur with Wiskott-Aldrich? Which part of the immune system is affected here? Let's see. And what is the defect actually in Wiskott-Aldrich? What gene is affected? What protein is not formed?
Was gene is affected.
Yeah, VAS gene is affected and VAS protein is not. What is the importance of VAS protein? What is this VAS protein doing? This is important for the integrity. That is the inside integrity of almost all the cells. Okay. Of the immune cells, of the T cells, B cells, megakaryocytes. So they are important for the integrity of the cell. So when this protein the VAS proteins are not formed, the T cells, the B cells, and even the megakaryocytes are not functioning in the going in the proper way. So that is paying way to the recurrent infection. How can you prevent infections till definitive treatment is got? That you will be able to tell only if you know, as I was telling in hyper IgE, there are so many things which are causing the infection. You should know what all are causing the infections in Wiskott-Aldrich. Okay, so we'll see it in detail. So Wiskott-Aldrich is a triad of thrombocytopenia, eczema, and recurrent infections. The pathognomonic laboratory finding is microthrombocytopenia, X-linked recessive. So just read with me. This VAS protein is needed for regulating the cytoskeleton, that is the acting cytoskeleton, and it is mandatory for the internal scaffolding of the hematopoietic cells. So I told you almost all the cells, immune cells like the defective T cells, NK cells, B cells, and even phagocytes. So you know there is a defective T cell defect. It's a combined immunodeficiency. When the T cells are also defect, NK cells are also not working. B cells are also not working. So the immunoglobulins are low. The phagocytes are also decreased function. And what will happen? The megakaryocytes are lacking this acting cytoskeleton. So they are failing to properly mature and fragment. So whatever platelets release the small platelets. So that is the reason for, platelets are formed by the budding of the megakaryocytes. Clear? So when the megakaryocytes acting cytoskeleton is not proper, the platelets are released, the release is compromised, small size, and moreover, these small size platelets are also cleared by the spleen. So I hope you understood. So this is a combined immunodeficiency, both cellular and humoral, and phagocytic also. And there is thrombocytopenia. Okay, so you have to give IVIG also to Wiskott-Aldrich patients till they for the definitive treatment of hematopoietic stem cell transplantation along with antibacterial and antifungal. Okay. So I think when we discuss a case of inborn error of immunity, we should never forget this child. Who is it? Who is he? Very cute. I showed a child initially, that was Jeffrey Modell. He was suffering from an antibody deficiency. He lived for 15 years and died in 1986. So from 87, this Jeffrey Modell Foundation came. So along with Jeffrey Modell, you have to know the name of this child also, who was called as a bubble boy. Samiha, who is bubble boy? Okay, this was David Vetter. Okay, so David Vetter from the time of birth, he also was born somewhere in 1970s, and he also lived for 14 years. And at the end of 14 years, he was actually suffering from severe combined immunodeficiency, was nursed in a bubble, almost like with perfect asepsis. And he had done a bone marrow transplantation at 14 years from his sister, but drastically he succumbed due to a cytomegalo Epstein-Barr virus or CMV infection, which he got from the donor. Okay. So this is David Vetter, that is a bubble boy. So thank you all for the patient listening. And thanks to Geeta madam, thanks to Purushothaman sir and all the PGs and faculties and IAP Kottayam for giving us an opportunity to be with you this night. Thank you all.
Okay. Thank you, madam. Geeta madam, anything to add?
No, it was a very nice presentation by Dr. Susy. And one small point I wanted to add is for Wiskott-Aldrich syndrome. When we look for the thrombocytopenia, the microthrombocytes, it is best not to do it through the counter. The main platelet volume on the counter will maybe falsely normal or higher when there is thrombocytopenia. So we have to go by the peripheral smear to look for the microthrombocytes. So that's all the small point. Okay, thank you.
Purushothaman sir.
Thank you, Geeta and Susy. That was a wonderful learning session for me. It was, now only I understand how much deviant I am from the recent advances and the Nelson textbook. And both the three of these, 3 or 4 of the postgraduates did very wonderfully, very well. Okay. Few point I would like to comment as a pediatrician, in fact. So in a case of when you are suspecting immunodeficiency situations, rather than this direct infections and all, the pedigree chart construction is so important. While you construct the pedigree chart, one very important thing is not to ask only for the recurrent infections and infection-related mortality in the family. You need to see and look for the appearance and photographs of all the family members if possible, because there can be a subtle clues apart from the infections. The facies can be the skeletal malformations can be the. So if possible, try to get a photograph of the previous generations and the siblings, and that is to be added on to the pedigree chart. That will be very, very useful for immunodeficiency disorder. Another thing is the other things other than the immunological problems of the three groups Geeta mentioned, immunodeficiency, autoimmunity, and malignancies. Apart from that, the clues in the general examination, the dysmorphic features and the features in the skin, features in the hair, because she was mentioning about the neonatal clues. One of the most important thing she wanted to tell, but to stop in between, was the facies. Look at the nose. The typical appearance of the facies with the bulbous nose is a clue for the DiGeorge syndrome. Can be a partial expression of this thing, and the mother may be perfectly normal, otherwise appearance, except for the appearance. So there can be subtle clues. There can be short stature and hair changes. So other than the immunological, there can be clues in the general appearance, not in the patient, but in the family members. That is very important, not only in this generation, the previous generation also. And one more thing I am very much interested is the clues in the other systems. You are mentioning about the myelin involvement, the neurological involvement. Always examine the other systems in detail, especially the angle jerk, because there can be clue for the peripheral neuropathy, because it's a degranulation problem, infections, the platelet degranulation, and the myelin problem. So angle jerk is a clue. So like that, other system involvement also, they may present with an immunological problem subtle. So especially in the siblings and the other members. So that's all from my side. About one question is about the injectable polio need in a case like this, especially when VDPV is so common. if it is a milder form of the Brutons and all, if they are visiting to a country like Africa where the more and more of cases of VDPV is there, shouldn't we insist on injectable polio? It may not be giving the high response to this thing. Still, I think it should be as a policy in India now. We don't have polio, we don't have VDPV at present, but people are going abroad many times, and there are a lot of countries, 150 countries are there now with the VDPV. So I think as a policy at the national wise, the visit outside for an older person also, we need to include the IPV, I think.
Yes, sir. We had actually 2 cases of SCID with the paralytic poliomyelitis.
Thank you. Thomas, we'll wind up. Huh?
Stop here, sir.
Very informative session. They learned a lot. Thank you, all of you.
Thank you.
Okay.
Thank you, sir.
Thank you, ma'am. Thank you, Susy madam. Thank you, Geeta ma'am. Thank you.
Okay. Okay, thank you. Good night, madam. Good night, sir.
Good night. Good night.
Good night. Good night.